Welcome everybody. Today's webinar is called Harm Reduction and Empowering Person-Centered Approach to Substance Use and Mental Health. My name is Kevin Myers. I'm the team leader at NEMHSCA's Dual Diagnosis Consultation Service. I'm also on the executive of the Yarra Drug and Health Forum, and I'm currently the chair of the Yarra Mental Health Alliance. I'm joined by my colleague Sarah Officer, who is the coordinator of NEMHSCA. We're bringing you a truly collaborative venture looking at the use of harm reduction approaches within a mental health setting. We'll begin by acknowledging the traditional owners of the land we meet on and pay our respects to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people with us today.
We would also like to recognise the important contribution to the design and delivery of health and community services by people with a lived experience and their supports. To begin with, if you would like to re-watch the webinar and share the link, please write down the websites on this slide. Today we're also meeting on Slido, and this enables you to interact with us. You should see on your screen you have the option to post your own questions and like other audience members' questions. Please do this throughout the presentations. We have set aside some time for a Q&A with the presenters at the end. If you cannot see these options, try going to slido.com and put in the event code 37978. We are live right now and open to the general public. Throughout the webinar, we will be referring to a harm reduction tool called Before, During and After, or BDA. The training package and tool has been created by Simon Cruz of Nexus Dual Diagnosis Consultation Service. Nexus is part of the Victorian Dual Diagnosis Initiative, or VDDI. The VDDI is a cross-sector initiative funded by the Victorian Department of Health and Human Services. Its role is to support the further development of mental health and AOD workers' capacity to recognise and respond effectively to people experiencing co-occurring mental health and substance use related issues. If you would like some amazing free harm reduction resources that you can access right now, you can go to Harm Reduction Victoria website. You'll find posters, pamphlets, info sheets, and more information on the training and workshops. We will talk more about all these training opportunities and resources in the Q&A at the end of the webinar. So let's begin our presentations. We will start our webinar by exploring what is dual diagnosis with Nexus Dual Diagnosis Consultation Service. Then we will hear from Harm Reduction Victoria about what is harm reduction. We will hear from 4 staff members about their experience using a harm reduction approach in mental health settings and conclude with a consumer story in the form of an animation. We'll see you at the end of the webinar to answer your questions. Well, welcome Kevin and Simon from Nexus Dual Diagnosis Consultation Service. So let's begin by talking about dual diagnosis. So what does the term dual diagnosis mean? Kevin, would you like to get us started?
Yeah, hi Sarah. At a most basic level, it basically means any mental health issue with any substance use issue.
And why is it important to consider dual diagnosis in our practice, regardless of what sector we work in? And what happens if we don't address dual diagnosis issues?
Well, first and foremost, mental health and substance use issues are very common across society. One of the biggest problems we have is that our service systems tend to operate on the idea of you either have a mental health issue or a substance use issue or a physical issue like, say, diabetes. In actual fact, mental health and substance use issues are bidirectional in terms of their influence. So if you only treat one of them, generally speaking, the other one will be tripping up, if you like, the treatment planning process.
And there are a number of approaches that we take in dual diagnosis, and I was hoping you could speak to each one of those. So let's start by talking about core business. What does that mean, core business?
A phrase that nicely sums this up is the idea of that dual diagnosis is the expectation, not the exception. So if you're working in a community health centre, a mental health setting, a drug and alcohol setting, or an emergency setting, a large percentage of your clients, in some cases between 70 and 90%, will have both conditions, a mental health condition and a substance use issue. Therefore, you should approach every consumer as if that's the case. And that means the ability to screen and assess for both conditions and make appropriate treatment planning based on that fact, rather than leaving the consumer to try to piecemeal putting things together themselves, which is a bit confusing for them.
And I think that leads quite well to the no wrong door policy or the no wrong door approach. Can you talk a little bit about that?
Well, again, the reality is that consumers and their family members will knock on a whole variety of different service systems, whether that's an emergency department, a GP clinic, a community health centre, and they won't necessarily walk in there with an idea of, I need to get my mental health sorted out, or my drug and alcohol sorted out, or my physical issues. And therefore, services need to actually have at least a basic understanding of how to screen and assess. They also need to have a basic understanding of how to navigate the service systems. So, for example, how you would access and which parts of the mental health service you would access and which parts of the drug and alcohol service you would access. Otherwise, the consumer and their family members are left to try to navigate very complicated systems.
And let's talk about the consumers. So one approach is called person-centered or person-centered care. Can you talk a little bit about that?
Yeah, a person-centered approach basically looks at the reality that every single individual will have a different set of circumstances and issues that they're dealing with. There are various different mental health issues. There are various different substance use issues. Some people might be experimental users of substances. Somebody else might be addicted to a particular substance. Some people might have bipolar, schizophrenia, so on and so forth. But also their social circumstances might be different. A homeless person might have different issues to somebody who's in transitional housing. Somebody with kids might be in a different situation to somebody who's in an aged care facility, for example. So that your treatment options need to take into account the person and their family context.
And talking about the person, what about a strength-based approach? Can you tell us about that?
Strengths-based takes into account the fact that individuals will come to you with an existing array of possible strengths that you can draw on. And that could be interests, that could be values, that could be their social support structures that occurred both in the past and potentially in the future. And by drawing them in, then you're more likely to have a sustainable treatment plan based on the skills and abilities of the consumer and their family members, rather than a plan which is devoid of things which actually, in a sense, drive the consumer to be able to achieve changes in their quality of life.
And I suppose that's a good segue to talking about another approach, the recovery-focused approach. What does recovery-focused mean?
Well, a recovery-focused approach came in a number of years ago now, based on the idea that rather than talking to consumers as if recovery is not on the agenda, if you like, it actually recognizes that there's a naturalistic movement towards recovery for most individuals if you provide the right environment for them. Now, one of those things, for example, is being able to celebrate positive success stories, recognizing that people will it's not a one-way traffic process. It's not like you go into, for example, a rehabilitation service and miraculously achieve a fantastic degree of recovery in a straightforward manner. There might be twists and turns along that journey. But if you're operating from a recovery-oriented approach, you're trying to grab the most out of each one of those occasions of care to help people to move on the journey that they're going to naturally move on to anyway, which is recovery-focused.
Thank you. That's a lovely definition. What about integrated care? This is really important for dual diagnosis. What does integrated care mean?
Integrated care essentially says that where there are multiple treatment providers, or if there is a single treatment provider, that all the various issues that the person is actually dealing with should be in a treatment planning process, rather than leaving it up to the consumer and the carer to navigate, for example, how their physical issues relate to their substance use issues that relate to their mental health issues. So putting it in very simple terms, if you have somebody who's prescribing medications for mental health issues, and then another doctor that's prescribing medications for, say, substance use issues, then those two practitioners should coordinate with each other to make sure that the medications do not interact with each other in a negative way. That's an integrated approach.
It really sounds like it's about treating the person as a whole rather than individual parts. And this brings us to the approach we're going to talk about in this webinar today, which is harm reduction. So thank you, Kevin, for those approaches. Simon, could you tell us a little bit about harm reduction? What is harm reduction? And after we hear about that approach, let's talk about the tool that you created a number of years ago, the BDA tool, which we'll be talking about today in the webinar. So let's start with harm reduction. What is harm reduction and how did it get started?
Thanks, Sarah. So harm reduction in Australia is a concept and a policy that's been around for over 30 years. I believe it's a fundamental human right to have your alcohol, caffeine, nicotine and other drug use issues treated in an evidence-based manner, just as we expect with any other health issue. And this is kind of what harm reduction is all about. It's really an approach about treating people's alcohol and other drug issues with a view to reducing the harm from that use without necessarily eliminating the drug use. It sort of sees that people might not be ready, willing or able to commit to abstinence at that point.
Yes.
So it's working to actually improve quality of life. That's what it's about. But I guess we should be realistic at this point. Most people in the world use drugs of some form or another, whether that be caffeine, nicotine, alcohol or others. Yes. And there's a whole lot of harm that comes from this. So we need tools that are going to assist us to reduce this harm.
So let's talk about this tool, your tool that you created a number of years ago. It's called the Before, During and After, or the BDA tool. So you started contemplating this maybe 20 years ago. Can you tell us a little bit about your journey for this in creating this harm reduction tool?
Yeah, so a long time ago, I worked in a very high volume service and I wanted a structure that I could easily use to help me explore harm reduction in a more consistent and holistic manner. And what I was seeing at the time was that harm reduction practice tended to focus on the actual use of the particular drug rather than what happens before and after. Whereas I thought that exploring before, during and after would give consumers and staff a richer source of information to develop, strategies, goals and treatment plans to reduce harm. So I decided to write the model up and test it out and see if it would work for other staff and consumers.
Yeah, we're going to hear from a number of staff members today who work in mental health settings who have used this harm reduction approach. Before we do, we're going to hear from Harm Reduction Victoria, just a little bit more about what harm reduction is. And I'll see you both at the end of this webinar for a Q&A. So thank you so much for your time. We'll see you at the end.
Thanks, Sarah.
Thanks very much, Sarah.
Harm reduction to me is a humanistic philosophy that seeks to meet people where they are and ensure that we respect and value our priorities in life day to day and shape a health system and a health response around taking care of people in the way that they want to be taken care of.
I've been able to steer clear of bloodborne viruses and I've been able to help educate people to minimise the risks and harms whilst they're using drugs.
The way I look at harm reduction is drugs are always going to be around. So why not look at it from a different lens and say, okay, yes, people are going to be using it and we can't stop them. We can help them reduce it, but we can't stop them. So why not set out plans to minimise the harms that come with using?
Hep C wasn't invented. Like when I got diagnosed, it was called non-A, non-B. They hadn't discovered it yet. So that was it. So that's why I got passionate about it, because it was new and exciting to me, harm reduction. Like as a concept, I'd never heard of it before.
In Australia, harm reduction really took off in the health sphere when HIV was rampant amongst a number of, priority populations. In those days, we were known as hard to reach and risk groups, but really we were never hard to reach. The situation was that services were not useful to us. People who are currently using require particular health services, and I think that we've come a long way in Australia in particular, in terms of understanding that and meeting people where they are.
We work specifically with the South Sudanese community. Talking about mental health and AOD is something really taboo to our community. So programs like ours, especially having a South Sudanese representative, benefits our community because now they have someone that they can go and get information from.
When I first heard about needle exchanges, I was sus on them. I thought, is this how the government's trying to follow us and know what we're up to? And, because you used to have a registration number to use the NSP, but then they got rid of that and it made sense. And I wanted to believe that the government wasn't just trying to get us busted.
I've been able to help steer my network of friends to education, information and services where they're going to be treated like human beings. Australia was really at the forefront of harm reduction. If we keep progressing and keep being the authentic voice for our community, and that's with consulting them, I think that we can keep achieving great things.
Although people may well wish to reduce or abstain from drug use, it's not always a linear path that happens very easily for people, and so harm reduction is a key part of the journey for everyone.
There's not a set narrative when you're a drug user. You don't have to end up in the gutter. You can be anything anybody else is. Harm reduction is an organic movement of community looking after itself. I'm not my drug use.
And I like to think that all the work that I've done has had a benefit for the community because it's had a benefit for me as well. It's a source of immense pride to me that I'm part of a movement.
As they might be scared of going to mainstream services, fear of judgment, fear that it might involve the police. If you tell someone that your child is using, they're fearful that the police might come. So a program like ours is really beneficial for our community because we're so sensitive and very brand new to this whole topic. People who come to us for advice and just ask us about, oh, hey, what's this drug? What's the effect of this drug? What's the effect on mental health? And we're equipped with all that knowledge to be able to tell them, and they go off and tell their friends. So it's positively impacting people because now people know the harms and the risk that come with these drugs, and they also know where to get help, where to go and look for services.
The North Richmond project, that was a community-based response, and it was about drug users being seen as a part of the solution, not just the problem. What we were able to see was a increased use of syringe disposal bins, as well as a huge decrease in syringes being left around the community and the housing estate.
For many years, I think that harm reduction and drug treatment, and law enforcement for that matter, were very siloed and seen as very different approaches to dealing with issues related to drug use. And I think that over the last few years, we've certainly seen drug treatment, or demand reduction as it's sometimes framed, engaging with harm reduction far more and being realistic about the fact that, although people may well wish to reduce or abstain from drug use, it's not always a linear path that happens very easily for people, and so harm reduction is a key part of the journey for everyone.
I guess it just gives them, it lifts off a bit of I guess, stress that they have to do all the work. Like now they know that our services are there, they just come to us, and we are the middle person who talks with them and helps them set out goals and stuff.
I think the biggest thing that I can ever do, is to be an example, is to be upfront about my drug use and not be worried about hiding it, because that just perpetuates stigma.
I've always been upfront and honest, and all of a sudden I had a boss that I was telling that I was a current drug user, and I know that made that boss feel really uncomfortable, but they stuck it out with me, and so then I was in this little bubble for a little while thinking that was okay, and it wasn't okay because we were seen as bad. So peer, should you say you're a peer or should you not say you're a peer? The evolution of peers, I still don't think we've come full circle. It's still not 100% cool to be a peer. There's a lot of us out here that are current users that have got great life experiences that we can transfer to work and to friends. We've still got a long way to go with peer. Yeah.
Hi, Megan and Aman. Thank you so much for being part of this interview. So firstly, we will explain that Megan, you're working from home today, and Aman, you're practicing social distancing at work. You've taken off your mask and you'll put it straight back on after the interview. So let's put this interview into context. So your workplace was trained in the BDA, or the before, during and after harm reduction model. And today you're going to share some experiences of using this model with consumers, and we'll hear some of those outcomes. So let's begin by talking a bit about PARC. So what is PARC for people who don't know?
Hi Sarah, thanks for having us today. So PARC stands for Prevention and Recovery Care, and the PARC program is a partnership between the hospital's mental health department, that's my employer, and Wellways, who employ Aman. PARC offers support to consumers, or participants as we call them, to step up from the community or to step down from the hospital's inpatient unit for up to 28 days. The aim is to support people to be able to develop the skills required to manage and improve their mental health and to prevent hospital admissions and readmissions. We have clinicians like myself on site in the week, working shifts in the day, and program workers on site 24 hours a day. However, there are periods where there's only one program worker here, and at times they're actually in the sleepover shift, so they're not available unless there was an emergency, such as, in the event of a fire. While the participant is at PARC, I will monitor and educate them about their physical and mental health, with discussions around their focus of stay, their early warning signs, and also how to keep themselves safe at PARC and also after discharge. This includes discussions and planning around how they'll use substances in an effort to help reduce the harm that they do to themselves and also to others. Aman, did you want to explain your role at PARC?
Sure thing. Thank you, Megan, and thank you, Sarah, for having us. PARC provides a safe space where people with mental illness are able to work on their recovery journey with the help of psychosocial and clinical supports. I am a social worker, and my role is to collaborate with participants and work on the elements of their self-driven recovery journey. It's a voluntary program and functions on the ethos of collaboration, and although groups are not mandatory, we work with participants at their pace. And that could look like catching up with their key worker and working on their self-identified focus of stay. The focus of stay is set by participants during the assessment process, and the nature of recovery journeys as such that most of the times these change. But the important part is that participants are supported in making that choice and taking full control of it.
Thank you. So maybe let's talk a little bit about PARC's policy on alcohol and other drugs, and maybe even just including caffeine and nicotine.
Yeah, sure. So Wellways have long practiced no wrong door policy. PARC implements harm minimization approach in working with participants, many of whom use substances. It is important to us that substance use doesn't become a barrier in accessing support. We engage participants to work with us to troubleshoot and plan substance use around how they will be managing that whilst working on broader recovery focus that leads to healthier lives and better mental health. Alcohol and illicit drugs are not allowed at park, and the reason being is so that park can continue providing a safe and recovery-oriented environment for all participants. It's important that we are consistent in our approach and support to participants, and we talk about our guidelines on substance use in the site tour, during assessment, and during site orientation when a participant enters park. Park guidelines say that substance use is not allowed at park, and if a participant is in the community and they happen to drink alcohol or use other illicit substances, then we would encourage them to be open and honest about it and support them in planning discussions and taking overnight leave.
Yeah, so we're clear about it from the start. No one can use alcohol or illicit substances either on site or before returning to park. If they feel like something, if they feel like using, then it's something that we ask that they talk about with us, and we can help them to either practice alternative coping skills so that they can be substance free, or to have us support them to prepare for overnight leave so that they can use in a safe possible, the safest possible way without impacting on the other participants. So basically, we're asking for open, asking for honesty and transparency. So people need support of each other to be able to build up mental health. And we recognise that for some people, having good mental health is about not using substances or being around other people that use, while for others, it's just about finding a way to do so without doing as much harm.
Yeah, absolutely. And it's also important for us to help and support participants feel comfortable in being at park. And this helps participants reach out to staff when they are thinking of using alcohol or other drugs. So a staff's role, or my role at that time, would be to have honest and open discussion with the participant and make a before, during, and after plan with them. The safety of the participant would be at the forefront of that planning discussion. And the purpose of park is to provide a replica of community setting for a participant. And so although we are aware that caffeine and nicotine are stimulants and they come with their own risks, we don't ask people to stop using them while they're staying at park. Rather, we work with them if they identify, or if we identify this as an issue, by exploring different options and to minimize the impact on other people.
Thank you so much. And you mentioned the BDA. So can you tell us a little bit about your experience using the before, during, and after harm reduction tool? How does this support your practice?
Yeah, sure. So my experience of using before, during, after harm reduction model is that it gives everyone a clear structure. It gives me a clear structure. It also helps me convey to participants that we are not asking participants to stop using their substance. Mm-hmm. And it allows me to create a space of collaboration where people feel supported in building their awareness and knowledge around their use. Within that collaboration, it then helps me in shifting their focus from the use of substance onto other various essential elements associated with recovery, such as safety, connecting with the community, becoming aware of different strengths, and creating autonomy.
Yeah, and the BDA has been part of the program since I started working at Park a couple of years ago. The BDA tool was explained to me by the Wellways team, and I found it really easy to use right from the start. Then when I attended the BDA training with Simon Crows, the training session was simple, straight to the point, and I remember completing a BDA tool on myself to get a better understanding of how it worked in reality. Yeah, it was really easy to use.
And we've had new staff arriving at Park recently in the past year, and the program coordinator has run a short education session with everyone to get them ready to use the BDA tool. And it was so easy to use that the team were able to roll it out again without any issues.
I really love that the conversation can happen without that written tool in front of you. So I had a walk around the park with someone the other day, and we talked about his binge drinking and how he was able to reduce the harm he was doing without really changing too much at all. So it wasn't really confronting for him. It's a great way to incorporate the public health initiative that ran a few years ago, Swap It, Don't Stop It, if you remember it. It was about getting people to think about small changes that they could make. So it didn't seem as daunting to be able, as daunting as giving everything up. And so you're able to improve your health. It's really about, again, just doing less harm. With this participant, walk around the block very casually, we talked about when they were at home and planned to drink alcohol to celebrate a friend. So we talked first of all about what they do before their alcohol use. So that was buying one bottle of spirits, instead of buying 3, as I'd done last time. Plus, they were going to buy a bunch of cans with a lower alcohol percent. Having a mixer in the fridge so that they are more likely to use that instead of just drinking the spirits straight. Eating dinner in the day as well, as he'd just get drunk and forget to eat and then drink way more than he needed to. We talked about during their drinking session, they'd actually sit outside in the yard with a friend, so they had to get up and go inside to grab another drink rather than just having that bottle of spirits sitting with them beside them. Pouring a big glass of iced lemonade to go on the side as well. Sure, if it was up to me, they'd be drinking water in between, but he hates water and it would have just sat untouched anyway. So when you compare filling up on a bottle of lemonade, it's going to do less harm than filling up on a bottle of spirits, or another bottle of spirits. Then we talked about after their alcohol session, what they were going to do, and it was having a plan to meet a mate the next day rather than just kind of moping around the house feeling hungover and then being more likely to drink any leftover alcohol. And also, just being kind to themselves. So these ideas are really about getting consumers to think about making small changes and stops rather than getting them to stop or telling them to stop and just coming up against resistance.
Would you be able to share a few more experiences of using the tool? Maybe Aman, did you want to give us another example?
Yeah, sure. Thank you, Sarah. I remember once working with a participant who used alcohol quite heavily, and they'd been drinking alcohol for a number of years. With their wish, we worked on before, during, and after harm reduction tool, which was both successful and helpful. Key learning for the participant was that it helped them become aware of the vicious cycle of their use. Alcohol was a coping strategy to numb their emotional pain and also to have social connection. However, it impacted their health quite heavily in an unhelpful way, and often left them feeling worse at the end. Often when they drank alcohol, it was to recover from the regrets of their last years, and the accommodation was also a huge factor in their frequent use of alcohol. They lived in a facility with more than 50 other neighbours, many of whom drank alcohol together. For the participant, they longed for the social connection, and alcohol came with it, and they couldn't deny it. At times, they felt very pressured to drink alcohol and to buy it for other people when they were within that group. The participant found BDA quite simple and straightforward. The before section of the plan involved that if they were invited to drink alcohol with their friends, they would practice assertiveness and respond by declining the invitation. They worked on assertiveness techniques with the key worker to help them prepare for that situation. The before stage also looked at buying in support from their friends by letting them know that not wanting to use alcohol was something they'd been working on, and if they would be able to help them in the process. The during stage looked at how would they drink in a way that wouldn't cause harm or cause less harm. The participant identified that if they joined their friends, they would take a non-alcoholic drink with them. This would allow them to continue having some sense of social connection whilst they were navigating their way through their emotional pain. The after bit of the plan helped them make room for instances where they did use alcohol, and then to not plunge in the motion of regrets afterwards, as it would likely make them wanting to drink again. The major outcome for this participant was that they decided that they were not going to drink anymore. The clinical team supported them with accessing pharmacotherapy for a very short term, and whilst maintaining their abstinence, they were able to liaise with other supports and were successful in accessing a different accommodation.
Oh, thank you, Aman. That's a really great example. Megan, maybe we should share the BDA plan and talk about the consumer that you worked with who made a plan around her cannabis use.
Yeah, great. Okay, so we've worked with a few times with a woman who smoked cannabis every day. She did this for many reasons, social connection, boredom, and just an attempt to manage her anxiety. We had honest discussions before admission about setting up a support plan for how she would manage without cannabis while at park, and she was able to reduce her own use a little at home. And then she had a 5-day detox admission before coming directly into park. Once at park, she worked on the BDA, and this is the copy you're looking at that she was happy for us to share with you. As you can see, her aim was not to be abstinent, but it was just to be able to get on and use without it really getting in the way of her other goals. I find that people can be quite philosophical when they use the BDA in talking about some of the ideas that they put down, and I try to get them to think more tangibly about the specific steps that they can take to manage and do less harm. So like in the before section, substituting an activity for smoking and also eating regularly in the day. During use, smoking joints rather than bongs, and also making sure that they clean the bong water if they do use the bong, and just using in a safe, in a safe space. Afterwards, looking at restarting their routine, get up out of bed, have a shower, have coffee and a cigarette, and start your day again. So they're much more realistic and achievable types of goals than say, you can see they're maintaining and attempt daily and long-term goals, or finding the good balance. So I guess, what do they really mean? It doesn't really give you clear direction on what you're going to be doing. So the BDA gives us an opportunity at that point to be able to discuss more with them around what those things mean.
Okay. Well, thank you so much. I guess finally, after using the tool with consumers and having all these experiences, what reflections do you both have about practicing harm reduction in a mental health setting?
Sure thing. Work that we do at Park is about ideas and planting seeds of hope and holding the space for the participant. So at times we may offer harm reduction to someone with a participant, but they don't identify their substance use as an issue. And in such instances, we acknowledge their view and encourage them to remain curious.
I've also found that there can be challenges in having consumers come to Park from other services or other teams where harm minimisation isn't maybe as strongly focused on. I remember working with a young person who was told, do not use any alcohol at all. And they actually felt that this was unrealistic. They weren't really sure how to move forward other than to just not drink. They're in their mid-20s, worked in a bar. Their social life was almost entirely focused around bars and drinking alcohol. And really for this person, the only reason they were sticking to the non-drinking was because while they're at Park, it was part of the rules. So basically when they were due for discharge from Park, they felt that they'd be going home and they'd go out and celebrate the end of their admission with drinking again with friends, but there was no real plan around how they were going to do this without going on a complete bender. So they had no idea how to get prepared to be able to use in a less harmful way. So with some clinical direction, the key worker engaged with this participant in discussions around, with the use of the BDA, and a plan was put in place for this person to take overnight leave home in the day, meet up with a friend for a few drinks as they'd already planned, but with a bit more of a plan, and then be able to return to Park the following afternoon. We had an interagency meeting before this participant took overnight leave, and there was a misunderstanding that the case manager documented in the medical records, saying that I'd client just go home and start drinking again. So for us at Park, it's about ensuring the discussions happen early on, and the reasons for the BDA and harm minimisation are highlighted with that team, and also documenting, it's important to document in your notes the reason behind what you're doing. So it's about really supporting the consumer to take charge of their own recovery while making their decisions and doing the least harm, the least amount of harm possible.
And that's a really great example too, and I'm hoping that in the Q&A section we can talk a little bit more about some of the challenges or some of the issues that might come up for staff when you're creating these types of plans. But anyway, I want to say thank you so much. That's all the time we have for this interview. We're going to go now and watch another staff interview, and I want to thank you both again for your time, and I'll see you at the end of the webinar for a Q&A. Thank you both so much.
I'd like to introduce Bronwyn Morrison, who is a registered psychiatric nurse working in a community care centre. So Bronwyn, let's begin by talking about what is a community care unit and what is your specific role there?
Yeah, thanks so much, Kevin. So a CCU is a community care unit. It's a residential psychosocial program providing 24-hour clinical care to those with a primary diagnosis of mental health. it's providing an opportunity to access intensive support towards achieving personal recovery goals. So they might be learning the skills to live independently, or establishing meaningful occupation and activity, and just having more control over their own health. So my role within the CCU is a senior clinician, and I help the team to deliver care towards best outcomes for consumers.
So specifically in terms of policies around substance use, both legal and illegal substances, you're operating through a hospital-based service. So can you describe how you deal with that issue within the CCU?
Yeah, so as you said, our service operates in an environment where illicit substances aren't permitted on site, and it's really important that that doesn't become a barrier to consumers in our program. So obviously, you know, the legal substances like caffeine and alcohol are permitted on site. Nicotine, because we're part of a hospital, isn't, but we have some workarounds around that. We also have a tenancy agreement because we're a residential program that provides some stipulations around expectations of behaviour in relation to substance use. So we really want to be able to work in a harm reduction way, and that tenancy agreement we changed after we implemented the BDA.
So that's quite a big change then from the older approach, which was almost you can't come in unless if you're using particularly illicit substances, so to lowering the threshold in a sense, so that people can actually engage in a treatment service environment that they need to move in towards recovery. Can you tell us about some of your experiences of using the BDA and what actually the implementation and training is like, and how did it support practice?
Yeah, for sure. So part of my role is about helping the team look for opportunities to improve practice and outcomes for consumers. So previously, staff really struggled to engage consumers around their substance use, and the consumers would be really worried about being evicted from the program if they talked about it. So we all wanted to look at what can we do better in this space. So we approached Nexus and, you know, felt that the BDA really fit with the recovery model and what our program was trying to achieve for consumers. So, you know, engaged the team in training and rolled that out, and yeah, really provided that as an opportunity for consumers within the program. It gave, you know, staff much more support in how to have that conversation with the consumer, and obviously helping the consumer to think about what it is that they can do to stay safe.
That's an interesting point actually about having a model of practice as opposed to just living it up to the individual worker. So having the BDA seems to have allowed that culture shift in terms of embedding practice. Can you give us some examples of how this looks in terms of a particular consumer?
Yeah, for sure. So I had the privilege of being able to work with a consumer who was transitioning from a correctional service to the CCU. And one of their biggest worries was resuming illicit substance use, where they had a goal of remaining abstinent and had worked on some strategies for what they might do when they felt urges to use. So when they entered the program, they did find it really difficult to abstain, and within the day they started using again. Initially, they were really afraid to tell me. They thought they might have let me down. So I was able to reassure them. They told me that their goal was still to be abstinent, but that maybe that was something that they could work towards. And so really thought about, you know, safer using and reduced using. So with that, it opened up the opportunity for me to introduce the BDA tool as a way to look at how they might go about doing that. So, you know, through conversation, we celebrated the things that they already do in terms of, you know, being able to know the impact of the substances on their health, both physical and mental health, you know, that they engaged in the needle exchange program, had a regular supply and a reliable source to get their substances from, you know, made sure that they had a means to contact the service if they needed to. And so then we're able to talk about what else they might need in order to achieve their goals, and really help them to be able to identify that for themselves.
It's a really interesting starting point, isn't it, to think that you're working with a consumer and engaging them in terms of looking for things that work for them, as opposed to you as a worker trying to come up with ideas on your own, even though I'm sure you've got some good suggestions. The working with, I think, which is an incredibly useful thing, because essentially it means that the consumer can be making decisions, even if they are using a particular substance. They're involved in that process of making, as much as possible, that use safer. And I think this is one of the things that we at Nexus have been talking about for many years, is that rather than either condemning or condoning substance use, what you do is you start off and say, okay, this is where the person's at the moment. How can we lower the threshold so we can engage them in conversation, maintain as much harm reduction as possible, and that in the very nature of doing that, that actually starts to lead people to working with you in other facets of their life as well.
Yeah, definitely. And it's really about supporting them to come up with what's going to work for them. They know what's going to work for them, versus, you know, my suggestions might not actually fit and how they want to live their life. So it's really important to be able to support them to have that control and choice.
Thank you very much, Bronwyn, for bringing us the world of the CCU and how you're using the BDA. We'll see you in the Q&A. And our next speaker is Erin from Mind Australia. So thank you, Bronwyn.
Thank you.
Hi, Erin, how are you?
Hey, I'm good. How are you?
Good, thanks. Thanks so much for being part of this interview. So for those watching this webinar, we implemented the before, during, after harm reduction package, or BDA, at your workplace. And staff were trained and mentored in the use of the BDA tool, and you've been using this treatment planning tool with consumers. So today, you're thankfully going to be sharing some of your experiences of the BDA, so thank you for that. Let's begin by talking a little bit about Sandridge House. So for those who don't know what Sandridge House is, could you please just give us a bit of an idea of what it is and what your role is?
Sure. So Sandridge House is a youth residential service that supports young people aged 18 to 25. Our residents have experienced or are at risk of homelessness and are also experiencing mental health challenges. Our residents are supported to set individual goals and work towards achieving these with one-to-one support from a key worker, and also in group settings as part of our psychoeducational group program. And these are really focused on mental health recovery, as well as building capacity with independent living skills and goal attainment. So I'm the team leader, and I support a group of 5 community mental health practitioners and 1 peer practitioner who deliver the program day to day.
Mm-hmm. And so what are Sandridge House's policies on alcohol, nicotine, caffeine and other drugs?
So Sandridge House policy states that the residents cannot consume, store, share or distribute illicit drugs, drug paraphernalia or unprescribed medications on the premises. So the purpose of this policy is obviously to keep residents and staff safe, but it obviously presents a number of challenges when supporting those who use substances regularly. Things like consumers finding a safe space to use and to store their substances, or feeling as though they may need to consume more because they can't bring it home with them. But at Sandridge House, we really encourage consumers to be open and honest about the issues that they're struggling with, and we definitely don't want them to feel at risk of losing their accommodation because of it.
Yeah, okay, so the focus is on quality of life and safety and health, essentially. Yep. So staff are given a 2-hour training session and 2 1.5-hour group mentoring sessions, so that's a total of 5 hours. How important do you think this training and mentoring is in terms of implementing this package?
The training was essential for us to have a deeper understanding of this model of harm reduction, and how to go about implementing the tool with consumers. The training provided the opportunity to engage in a lot of experiential learning, so we could really feel comfortable when using the tool. And the mentoring sessions were an opportunity to come back together after using the tool with consumers and to share experiences and ask questions. So the whole process really helped to cement the tool into our practice instead of just having it there in the background. The whole process allowed us to really embed the BDA tool into our everyday conversations and our support model, from intake all the way through the 12-month journey and beyond. The tool's really person-centered, and it's a collaboration between the consumer and their support worker to explore issues and develop strategies.
Fantastic. So can you tell us a little bit about your experience of using the model?
Yeah, sure. So initially I saw this as a really great opportunity for the team to upskill and to feel more confident supporting residents. Most of the referrals that we're getting are for people with dual diagnosis, and I found that we really needed to adapt our approach and have a clearer plan for how we can support those consumers and work more effectively in this space. Our experience has been that when you regularly focus on safety with a consumer by using the BDA, it really builds trust and understanding, and it's helped to inform really individualised approaches to harm reduction strategies and conversations.
Right. So was it useful for your consumers?
Yeah, the feedback that I get from consumers is that they really like this tool and this approach. It helps them to feel really in control. A lot of the discussions that come from using this tool really highlight to the consumers things that they are already doing to keep themselves safe that they may not have been aware of. And it also brings to the forefront potential risks that they hadn't considered and how they can self-manage those in really simple and achievable ways.
So it helps keep them safe and healthy.
Absolutely.
And was it useful for staff members?
Yeah, look, throughout the whole experience, I've seen the confidence levels within the team grow. And I've had team members identify ways that we can use the tool with our residents regularly, looking at a referral and saying, this client's presenting with this issue, I'm going to use the BDA tool with them during intake. Yeah, it's been really great.
Great. So that's some good evidence of sustained change too,
really,
I guess. And in terms of just overall for the service, was it useful for the service, do you think, to implement this?
Yeah, so previously we were using different AOD screening tools and identifying that, okay, perhaps this resident would benefit from some treatment or support, but what does that look like within our service? If they aren't ready to engage with an AOD worker, what else can we do in-house to keep them safe until they're ready? For us, this is something that we can do now really confidently to create a safe space for conversation and stepping towards recovery at their own pace.
So would you say it could potentially assist with integrating your practice with an AOD service when the consumer's ready?
Yeah, absolutely. It's been really beneficial to have that conversation and prepare them for that space when they are ready.
Yeah, fantastic. So would you recommend other health and welfare services be trained in this approach?
Yeah, absolutely. Look, I have done already. I think anyone looking to upskill their team for supporting consumers with dual diagnosis, anyone who wants to approach harm reduction in a really practical way with confidence, this tool is really, really beneficial. It's empowering and it provides a really person-centered plan to work towards with consumers throughout their journey.
Fantastic. Well, thanks so much for your time today, Erin. It's been great to hear your perspectives on the BDA harm reduction package. Now we're going to hear about an actual example from one of your consumers, so I'm looking forward to that. Let's take a look and we'll see you all at the Q&A session. Thanks again, Erin.
Great, no worries, thanks.
Living on the streets isn't always too fun. You get a lot more problems than you think that pushes self-esteem down. My alcohol use was pretty much as much as possible to not only just numb a bit of the pain every day, to sleep a little longer at night, to make me feel more relaxed and at home for where I am at the time. There are some programs that can help in that. When you first enter there's a big line of questioning on what do you use if you're a user of any drug or alcohol or substance like that. And if you are a user of any of them, you're told that you're not allowed to have it on the side at all. They don't always give you ideas on how to go through the emotions and that. A lot of people don't know how to. You can't just quit cold turkey and it work all the time for everyone. Some people can do it. I kind of started spiraling a little bit again and I'd go out every night, have drinks and then come back and sleep. Felt like a bit of a rat in a cage at that point. Feels a lot better than the usual approach that I pretty much got, which was on how to stop using. more of how to stop harming yourself while using. People being shown that they can do something for themselves instead of having someone always hold their hand and do it for them. It shows that you have control and you're the adult. Definitely it being my choice instead of someone else's is definitely the best way to put it, because you never want to be told what you have to do as an adult. You've been there, done that in life. Once you're making your choices and you want to help yourself, this is the way to do it.
Well, welcome everybody to the Q&A section of this webinar. Thank you so much for your time. We really appreciate you sticking this through to the Q&A section. So let's begin with a quick poll. So we wanted to send a quick message of thanks and encouragement to the consumer with a lived experience from Mind Australia. So if you could use your Slido function, you'll see poll up on the side. If you like this animation, you can please leave him a couple of quick words of gratitude and encouragement for sharing his lived experience story today. So while you're doing this poll, we are going to go through the panel and just talk about who's here today. So we have Simon Cruz and Kevin Myers from NEMHSCA Dual Diagnosis Consultation Service. We have Megan and Aman from PARC. We have Bronwyn from the CCU, and we have Erin from Mind Australia. Behind the scenes, we have Nick Wallace from Harm Reduction Victoria. And my name is Sarah Officer. I am the North East Mental Health Service Coordination Project Coordinator. Okay, so let's launch another poll. We would like to find out where you're from. What sector do you work in? Or are you a lived experience person or a carer or a family member? So you'll see another poll should come up on your screen asking you to type in with one word. And let's have a look at that poll and see if we can get people up on the screen. There's quite a few people from AOD, I see. Mental health. Very good. Youth justice, counselling. Oh, that's great to have you here. Got a lot of mental health, a lot of AOD. Students, welcome to all the students. Thank you so much for joining us and thank you for sticking in with us. So let's start our Q&A. Okay, so we've got a few questions to go through today. We're going to start with the first one by Joy. Can we have a look at the Q&A up on the screen? Okay, so is it possible to have some of these definitions from the beginning of the webinar written down and sent out? They are fantastic for clarity. So Kevin, maybe you could talk about this. We've been talking about this behind the scenes.
Yeah, hi, Sarah. Yes, look, what we're going to do is go through all of the questions that we've got and look at the material. Any material we've got, we can try to make into a document that will be on the Yarra Drug and Health Forum sites, the NEMHSCA sites, and we'll make sure people have got that available. It might take us a bit of time to do that, but hopefully by the end of the week.
Yeah, it's a really great idea, and I think it's a really valuable resource. So we'll put something together. We'll get those definitions and the approaches, and I will, whoever's registered to the Eventbrite registration, I'll send it through to your email, hopefully in the next week or so. Okay, so maybe let's go now to the next question. Can we have a look up on the Slido slide questions? Okay, so other than CAT, what resources, services are available to assess and offer immediate support to people at the point of crisis? So maybe, Bronwyn, would you like to talk a little bit about this question?
Yeah, thanks, Sarah. So I guess it would really depend on what the crisis was and what was happening for that person as to what would be the best service to respond to their needs. So there's always things like, going to the emergency department, calling 000 for a first responder. If it's AOD related, direct line could be a service that could be used. For people to know that mental health services in general are expected to respond to dual diagnosis needs for anyone, whether that's in crisis or not.
Yeah, thank you so much, Bronwyn. Okay, let's have a look at another question. Okay, How do we access training for the BDA tool? This is a good question. Maybe Simon, you could answer this one for us.
Yeah, so currently the best way to access it is to drop us a line at nexus@svha.org.au and just tell us a bit about who you want the training for. We generally roll out the training to teams rather than individuals. So the best way to do it is to have a conversation with us about that.
And Simon, am I right in saying that this is for people in the state of Victoria?
Not necessarily. I mean, Nexus is a catchment-based service, so we work with a whole range of services in the northeast. But there is potential to do it outside of that area as well. So it's really it's kind of, we need to discuss it on a case-by-case basis, I guess. Yeah.
And is it free for teams and organisations, or is there a fee involved?
Yep. So for our stakeholders, so the stakeholders that we're funded to service within the Northeast catchment, it's free. Outside of that catchment, we'd have to negotiate costs, etc. It may be free depending on the situation. It's something we really need to do on a case-by-case basis.
And Simon, I was just wondering, can you just very briefly just talk about what the training entails, what that would look like for people? So how long is it, and maybe a little bit about the mentoring part of it as well?
Yep, sure. So we have an implementation plan that we do with organisations. So we would have a meeting with the person's organisation, with the team's organisation, work out, whether they have a harm reduction policy in place. So we basically set the scene initially. Once that's agreed, then we look at logistics, like how we're going to train staff, when we're going to do it, that kind of thing. The actual training of staff, that component is 2 hours. And then we suggest, and within that, there's an experiential component. So people use the tool on themselves for a particular drug, whatever they choose. Then they're expected to use it with 1 or 2 consumers, and then they have 2 follow-up group mentoring sessions. And the group mentoring sessions are really a really good professional development opportunity for people to check in how they're going with using the tool, sort of troubleshoot any issues, also to celebrate positives and gains. Yeah.
Okay, great. Thank you, Simon. Okay, so let's have a look at another question up on Slido. Okay. So Daryl asks, Kevin mentions that dual diagnosis amongst AOD clients is the expectation, not the exception. Is service coordination between AOD and mental health services right? And how can it be improved?
Yeah, thanks for the question. If we go back in Victoria, back in 2008, the state government brought out a document called Dual Diagnosis Key Directions for Service Development Outcomes. And I think it lays a very clear message to people that said that services need to operate on the basis of expecting a large cohort of their consumers will have a dual diagnosis, and therefore they need to coordinate with other services to ensure that, as far as possible, consumers don't fall through the gaps that were created by the siloed approach. And Nexus has been very clear that what we do is we go out and we introduce people to each other in terms of different services. We look at cross-sectoral training. We bring in tools and resources like the BDA, which can be used in numerous different service types to respond in an organised fashion to the issue of dual diagnosis. And frankly, people are actually responding well to that once they have a tool that assists in that process.
Simon, did you want to add anything to that about service coordination, or maybe what we could do as workers to better promote this cross-sector, which probably shouldn't be a cross-sector, but this cross-collaboration?
Well, I guess, from my perspective, workplace tools like the BDA and RFUP and CCA and so forth, they are useful for coordination, because if you've trained people within a particular area and they're all on board with the same tools, you get a much more consistent response. What we've got at the moment is we have a fairly inconsistent response, I guess, because different people have different ways of doing essentially the same job. So if we can get people on more of a even sort of playing field, I think that's a better way to go, and that's something we're working towards.
One of the issues to add in there, sir, is that Most of the issues that workers will be facing and services will be working from include some of the basic things, such as the ability to engage well, build a rapport, understand the circumstances within which people are actually living, who are their support structures, what are their hopes and dreams. Yeah, all of those issues are the same. So it stands to reason that if we actually engage with people around those things, then we will be able to, should be able to work more closely together with our other services as well.
I think another element to that, sorry to chop in there, but another important element is to think about networks, how networks work across these different sectors, because that's one of the few ways we have to actually speak to each other and improve communication between the sectors. And I think that, communication is the key to working in a more integrated manner. Networks are fundamental for that, I think.
Yeah, and I think today's webinar is a really good example of that. We have the NEMHSCA, the Northeast Mental Health Service Coordination Alliance, we have the Yarra Drug and Health Forum, and we have the Yarra Mental Health Alliance, all involved in contributing to this webinar, as well as about 5 or 6 different organisations. Okay, let's go to another question. Can we bring up the slider? Okay, what are some of the best harm reduction strategies? So maybe I'd like to hear from some of the staff members. Maybe we'll go to Megan. What about you from Park? Can you talk a little bit about some of the harm reduction strategies that have worked at Park for you?
Yeah, sure. So I guess it's, we're looking at people just individually and creating plans with them that are, specific to each person, because we're all so different. So and the way we use substances is very different. Often it'll be that we have people, if they're smoking cannabis, they might be doing it through a bong, just like, the example I gave with the BDA. And so just swapping, not having nicotine when you smoke that bong, or making sure that, there's other options, being able to smoke out of a joint, rather than from a bong. Being able to mix drinks, a lot of people with mixing, soda rather than just drinking straight is another one. And just kind of being prepared, letting someone know what you're doing, having your substance use be with a friend is really important as well. A lot of people are doing this on their own, and so it's very individual.
Thanks, Megan. What about you, Aman? Can you pass on any?
Yeah, sure. Thanks, Sarah. And I agree with Megan. And as a worker, the helpful strategy as a psychosocial worker is always holding the space for the participant. So really acknowledging where they are, what they want to work on. So some of the common strategies, some of the helpful ways that participants have come up in the past is swapping something else, minimizing the quantity, not having too much on them, making sure if it's alcohol, eating something prior to the use. And sometimes recently it was converting that urge of using into something more meaningful, such as inviting family friends over and doing this whole cooking up something. But yeah, it all needs to come from participants. Yeah.
Thanks, Aman. What about you, Erin?
Yeah, I think, look, the consumers that we're working with in residential at Sandridge, the strategies that we find to be most effective are the ones that are the most meaningful to those consumers, the ones that they're coming up with themselves. So the BDA is, we use it as it's the conversation starter. It's the thing that you use to discuss potential harms and how they're going to go about, removing or avoiding or reducing those. And the ones that we find are the most meaningful are the ones that they can come up with themselves, and it doesn't even need to be something that's directly related to the substance use or whatever it might be. It can be things like having a really strong routine in place every day so that they've got activities, they're linked in with meaningful activities, employment, education, things that are really meaningful to them that are going to help them to support that, working through that process to eventually look at their use when they're ready to do so.
That's great, Erin. Thanks so much. Bronwyn, what about you? Were there any strategies that you found the most useful working with consumers at CCU?
Well, like everyone said, it really comes down to the individual and what's going to work for their circumstance. But I guess one of my favourites has always been start small. You can always have more.
That's great. That's really great. Simon, did you want to talk a little bit about, I think the message here really has been there is about empowerment and empowering the consumer to make their own decisions, make their own plans, choose what works best for them. Can you talk about empowerment?
Well, I guess just to add to what everyone else has said, with through the using the BDA tool, it's a combination of the consumer's knowledge and experience and the workers' knowledge and experience. So I think people are a little bit humble and not talking about actually the role that they play in bringing that about. So I guess in terms of empowerment with the BDA tool, once you've explored the issues with the person, and the BDA tool can be done fairly quickly or it can be done over a long period of time. There's no real set time that it needs to take. It can be revisited on multiple occasions. You're trying to build up the consumer's insight into their own use and ways to reduce harm, and it might be that you suggest ways that they can reduce harm as well. But again, it's the consumer's choice whether they take that on. What we've found with rolling out this tool is that consumers do feel more empowered by the process and actually make more changes because, as the other staff here said, the strategies they pick are more realistic for their circumstances. I think we too often fall into the trap of we set an example for somebody that's actually too hard for them to get to, and then there's just disappointment on all sides. Whereas with this tool, it's about looking at what's a realistic goal that the person can actually achieve and working towards that.
Yeah, and I think sometimes we've often spoken about putting ourselves into the consumer's shoes. And I think sometimes we ask the consumer that they have to come into a service and they have to stop using a substance. But if we ask ourselves, tomorrow you need to stop drinking coffee, how difficult that would be for us. And so really creating those realistic plans. What is realistic for the person?
Yeah.
And we all know within ourselves what's realistic. Kevin, did you want to add? Sorry, Simon.
So I was just going to say, I think it's also important to, for a lot of people, just saying no doesn't work. So it's not really that, it's not helpful. It might feel good as a staff member to simply say, just give it up. But actually, we've got to think a bit beyond that and think about, is this actually going to help the person? Is this the aim of the healthcare we're providing? Is it just to say no and hope that they go away and then we think it's job done? There's not a lot of evidence base for that approach.
Kevin, did you want to add anything to that question?
Well, I was just going to make the point as well that often involving peers and significant others in this conversational way of looking at harm reduction, I'm sure there are lots of people out there that would recognize that if you just tell someone, don't do this, don't do that, people have fantastic intentions. Nobody goes out on a Friday or Saturday night saying, I'm intentionally going to cause myself more harm. But giving people the ability to think about those issues actually means they're going to have more options at the time. And you can also have situations where, a couple of friends might actually go, okay, well, look, if this happens, this is what I would like you to respond with. Don't just leave me in the middle of a chaotic situation. Here's somebody who I can ring. This is how I want to get home. Even down to things like saying, well, there might be a specific person to call if something happens. So sharing that load, if you like, and making people be open to discussing and learning from each other is the way we've actually increased our understanding of a whole lots of different issues over time. And the consumers have got some fantastic ideas as well if you allow them the opportunity to think about it and bring that into the mix.
Thanks, Kevin. All right, well, let's go to another question. Let's have a look at the Slido. So what are some examples of culturally appropriate responses and how relevant, important are these to harm reduction? So maybe Bronwyn, did you want to speak a little bit about this question?
Yeah, so the way I see it is that every part of who we are makes up our culture and our cultural identity. So it's going back to that person-centered, individualized approach that the BDA allows. So it's really about what fits for that person. So whatever that might mean for them in terms of, I guess I can give an example where at the CCU we worked with a a consumer who would go to church every Sunday and would also smoke cigarettes, and was told by the church that they needed to stop smoking and they couldn't come to church if they were smoking around the church or needed to go have cigarette breaks. And so in that conversation, they were able to identify how meaningful, going to church was, what connection that gave them to their cultural identity. And, they came up with ways, like using nicotine replacement therapy so that they could still attend church and not be kicked out of that, cultural religious space.
Hmm.
Oh, thanks, Bronwyn. That's really great. All right, well, let's go to another question. Okay, are there concerns with sending consumers home when they might be drug affected and less likely to have supports if living independently? So would somebody like to answer that question?
I'm happy to say something about that, because we do have that as an issue at Park. Of course, people can't stay on site having used substances, including alcohol. So we need to make a plan with them to be able to go and keep themselves safe at home. It's really about having a conversation with the person before it even gets to the point where they end up maybe up the road having lunch and end up drinking alcohol and just, recently we had someone who had a friend call us and say that they, a consumer that was staying with us at Park had called them really worried, thinking they're going to get kicked out, they'd broken the rules, they're not able to come back. And so first of all, it was about talking to that friend about what they could offer for the person it was really just having a night away from Park, and then making a plan for me to be able to call the person. They had their phone on them. We had a chat about how they were going to look after themselves over that 24-hour period, included getting some dinner, calling their ex-partner who was quite supportive. So having that person around, it was a little hard to have the discussion because they were so intoxicated. So it was just keeping things really simple. You need to be able to go home and set these things up in motion. So, we went and had consent from them to be able to grab their house keys from the room, some money, and actually went up the street to meet with them so that they didn't have to come back and be intoxicated around other participants who are, also some of them are trying not to use alcohol. And then that friend had a plan to be able to visit them the next day and see how they were going, and then they could come back to Park. But we sent a text message to them with the support phone numbers that they could call if they weren't managing, and just reassured them that we were actually really grateful that they'd been honest and had let us know what was going on so we could work with a plan. So on their phone they had access to the crisis line, also a 24-hour support line for people that are thinking about suicide. But when I called them and they're on their way home, they actually had stopped off and grabbed a pizza. So there were, moments in time that we'd planned for to be able to offer them support. And, they came back the next day, and we've made a plan for if that does happen again, what are they going to do? It's not a sort of fly by the seat of your pants kind of situation. We've got more of a plan in place if they do drink while they're out. But it's not about just sort of sending someone home and saying, right, get out of here.
It's such a great example. It's such a great example of why planning is so important, and working with a person, what's going to work best for them. That's excellent. Thank you, Megan.
I guess elements like that can be drawn out through using this type of tool, because you could potentially identify that there's particular high risk situations for a person and then do some planning around that, rather than just sending them off to who knows what.
Exactly. Thank you. All right. Well, let's go to another question. Let's look up on Slido. This webinar refers to a lot of AOD issues regarding harm reduction. But what about mental health? Is there a harm reduction framework for mental health? Kevin, would you like to talk to this question? Well,
from our perspective, dual diagnosis would actually look at the idea that AOD and mental health can't be separated. They are actually bidirectional anyway. A lot of the policies that come out are connecting those dots. If you think about, say, harm minimization, harm reduction, that policy may have been going for 35 years, There's no reason at all why mental health services can't see themselves through that lens and use those ideas. But we have specific mention of the need for mental health services to recognize and respond to drug and alcohol issues as well. I would argue that in the same way, if you look at, say, a prescribed medication for mental health, like olanzapine or benzodiazepine, then you can still use a harm reduction approach with that medication, because you would look at, okay, what happens if I stop it suddenly? What if happens if I take too much? Where would I actually keep the medication if I've got children? How would I not take that medication with other medications or with other substances that might actually cause me to have a major physical problem? So the same issue is applying. You're still using a harm reduction philosophy around mental health issues. If I've got, for example, bipolar disorder, we know that under certain situations, for example, if someone was manic or depressed, they may use different substances at different times. So you would actually still use a harm reduction approach to look at those scenarios and actually make some plans.
Thanks
I also
so much,
say there, Kevin, I think you mentioned olanzapine. A lot of the people we work with take medication that will increase their appetite, make them sort of feel less energized and be able to get out and exercise. So weight gain is a big problem. And, we will use harm minimization when discussing that with clients. So, the other day I was chatting to someone and I'd gone into their room and they had a huge supply of junk food sitting on their bench. And we just talked about, they'd just been talking to me about wanting to lose weight and feeling constantly hungry. And, just small steps like being able to put that junk food down, so it's out of eye level kind of view, putting it down in a drawer and maybe having some fruit or some healthier snacks up on top of the bench. So that's the easy go-to spot. So it's in everything that we do, harm minimization is part of it.
I think also it's an element of the BDA tool is looking at harm reduction in relation to mental health and AOD. So yeah.
Excellent, thank you. And Erin, I just want to ask you about the consumer in the animation. Can you talk to us a little bit about him and how did he feel after, creating his own BDA plan and implementing some of the strategies? And did that build his confidence, his empowerment for somebody who hadn't probably used an approach like that before?
Yeah, well, I guess you were really probably able to see the confidence coming out in the animation, and having him actually say, yeah, this is something I want to do. I want to share my story. I think 12 months ago that never would have, he would have been so reluctant to tell his story or, afraid. His self-esteem has definitely come such a long way since, moving through our program, becoming a lot more independent and still working with us on things like, looking at substance use and looking at ways. I think it just really promotes that next level of independence. Now you're more independent, you're living independently. How can we work with you so you can support yourself independently? And it's really, he's doing really, really incredibly well. And the way that he speaks about, this tool when he used it with his key worker and the way that he reflects on that, from my perspective as a team leader, hearing the way he talks about it and discusses it in such a positive way and just seeing his energy and seeing his motivation and, hearing him come up with, suggestions or ideas or new things. It's just like, it's such a contrast to, where he was at 12 months ago. So, I think this is the sort of tool that has nurtured that, it's empowered that, because it's not us, giving him a list of things and saying, well, which do you want to do? Or, it's still giving him options, but this is really about like, it's about you. What do you want it to look like? And how is it going to be meaningful to you? How are you going to use it? And, he's a realistic person that says, oh, yeah, if it's not meaningful to me, I'm probably not going to use it. I'll probably throw it in the bin. And he hasn't done that. He's actually still using the strategies that he was able to come up with all that time ago. And he's still, he's set himself goals and he's actually doing them, and he's coming up with more and more every time I see him. So.
Yeah, well, I suppose it's like flexing a muscle, isn't it? When you start to create plans for yourself, you start to set your own goals and you make your own wellness plans, and then you start to achieve those, or you follow through with your plan. You build your own self-efficacy and confidence. So it really is like an empowering approach to use with people. And I think sometimes we forget that small things like that are really empowering.
That's right, and because they're such really achievable. It's that, short-term gain kind of stuff. They're not having to wait 12 months to see the outcomes. They're not having to wait, to achieve these huge goals. They're really realistic goals that they can literally achieve within 2 hours.
Yes.
So,
yes.
It's, I did that, tick. I can do it again. It's
exactly.
Yeah, and it's definitely, it keeps that motivation going, which is something that we don't see a lot with that bigger kind of stuff, interventions.
Aman, just before we finish this question, did you have any reflections on some of the consumers you've worked with at Park about their self-confidence and creating some of these plans?
Well, yes, I do. Thank you. One of the people I recently worked with had an issue with drinking too much of coffee. And for that person, they benefited from engaging in these planning discussions while they were at Park so well that they said before they left that they will continue acting or using that plan, working on that plan. Yeah, and what was really helpful and what has been quite helpful in my experience in supporting working with participants managing their different substances is that getting support in from the other significant others, so family members or professionals or anyone who holds a lot of meaning for that person. If we collaborate with them in those discussions, the participant seems to benefit quite a lot. Yeah.
Kevin, did you want to quickly speak to maybe support people, carers, families? And how
look, I think it's an issue that is often leads a bit of confusion. We use the term person-centered approach, and what we mean by that is that actually means that, as Bronwyn was saying, what is the person's family background? Who are their significant supports? How do you actually work with them? And those significant reports might be their wife, their sons and daughters. It could be their next door neighbor. It could be an employer. There's a whole range of different people, and I think, as Aman was saying, you are looking at how does this interact with each other, really. And for some individuals at certain times, some people might play a very, very key role, and that understanding will make a big difference. One of the things that's surprising for me over the years has been that working in mental health services, where people have done discharge planning, for example, without actually consulting the very people that will be working with or living with the person when they leave a hospital environment. Now, it makes no sense at all to do it that way, because that means that the significant others and the carers have not been involved in thinking, okay, what do I need to be aware of in terms of relapse prevention, for example? What do I need to be aware of in terms of the treatment plans? What's the next appointment? What's the new medication they might be on? How might we respond in terms of if their mood changes? How would we recognize changes to their mental health generally? All of those things means you're working with the person in the social and economic context within which they are living.
If I could just add to that, one way to conceptualize that is that the carers are often the treatment team, and that services are the pointy end of that treatment team. So if you think about that, it's about how you integrate your work as a service with the family or the carer, whichever term you prefer.
Can I just add a little point there, Sarah, that we're talking about discharge? I think the other thing to be aware of is that if you take into account that a vast majority of consumers of mental health services, for example, will also be using a variety of different substances, whether that's coffee, alcohol, nicotine, cannabis, heroin, you name it. That means that anybody that's been or is likely to have an issue where they may need to go into, for example, into a hospital environment, then you should be using something like the BDA to discuss where you're at now and to plan for that possibility. So, for example, you would think about, how would the person who's been using nicotine products, how would they respond to being in a smoke-free environment? How would you actually support somebody who's been using, say, ice? They come into the service. If you at least have understood what are the issues that they've been working with previously, then you can start to make a plan, and that means that there's less problems when someone's actually admitted, because you've thought about how you would respond.
Thank you, Kevin. And that is probably an excellent way for us to finish up the Q&A section, because we have run out of time. That's gone so quickly. So we would like just a little bit more interaction from you. We would like to launch our second to last poll. So we want to know, has this webinar increased your knowledge about harm reduction and harm reduction approaches and why they're valuable? So if you go ahead on your Slido, you should see a poll, and that should pop up for you. And maybe we could look at the results if they are coming through. Oh, very good. That's excellent. I'll give you just a little bit more time to complete that, and then we'll move to our second poll. Okay, let's launch our second poll. So after watching this webinar, would you consider using harm reduction or a harm reduction approach with your clients? All right, let's switch to that last poll. There we go. Oh yes, that's good.
A good number.
That's a good number. Well, thank you all for coming through to the end. We appreciate your time so much. We are going to play a small video where I'll talk about, I'll put the Nexus email address, the Harm Reduction Victoria website as well, for free resources that you can download and print off and use right now. I will also send any updated information that we have over the next coming days through anyone that's registered through Eventbrite. So I wanted to thank all of the staff members from Park, Mind, the CCU, and Nexus Dual Diagnosis Service, and Harm Reduction Victoria. We hope you enjoy the rest of your day. Thank you for watching, and see you later. Bye. Thank you for watching the webinar today. We really do appreciate your time. If your organisation or team would like to be trained in the BDA, please contact Nexus Dual Diagnosis Consultation Service at nexus@svha.org.au. If you'd like to rewatch the webinar, you can go to the Eastern Melbourne PHN website and search NEMHSCA for all our webinars. You can also find the webinar on the Yarra Drug and Health Forum website. You can also find resources, workshops and training opportunities at Harm Reduction Victoria. We would like to give a special acknowledgement to the consumer who shared their lived experience story today. Lived experiences are what shape our service system, especially stories about what works for the service user. We hope these positive interviews and outcomes will continue to promote recovery-orientated, person-centred, collaborative and integrated care. This webinar could not have happened without the technical support of live streaming services. They have made the experience of live streaming seamless and stress-free. And the absolutely beautiful animation was created by Shom Productions, two companies we could not rate higher. Please find their details on their websites. Lastly, we must acknowledge the truly collaborative effort that went into the making of this webinar. I would like to thank every staff member who used their precious time to record interviews, and every alliance and organisation that supported this webinar. We hope you have enjoyed today. Take care and stay well.